Okay, everyone. Well, we'll go ahead and get started now. It's my pleasure to introduce today's visiting professor with us, Dr. Michelle Josephson. Excuse me. Dr. Josephson is a professor of medicine and surgery at the University of Chicago and is a nationally recognized recognized leader in transplant nephrology. She actually founded the transplant nephrology program at the University of Chicago in 1992 and has served as medical director for over 3 decades before just recently stepping down in 2023. In 2001, she also established the Transplant Nephrology Fellowship Training Program there, which was the first of its kind in the state of Illinois, and currently serves as program director as well as the director of education for the Transplant Institute. Dr. Josephson has played a major role in advancing transplant nephrology through her clinical leadership, scholarship, dedication to education, and mentorship. In recognition of her impact on the field, she served as the president of the ASN in 2023 and is the recipient of numerous distinguished honors, including the ASN Barbara T. Murphy Lifetime Achievement Award. So I think we are very fortunate for the opportunity to hear from her today. And so please join me in welcoming Dr. Josephson.
Thank you. It's really been a pleasure to be here and to have an opportunity to meet and talk with some folks and see some old friends and get to meet some new friends. Just want to make sure everyone can hear me okay? Okay, great. So after the last talk, I'm thinking maybe I should have changed this title to AI. Should we keep transplant nephrology? but anyway, so today I want to sort of talk a little bit about a question, well, this issue. And I'm hoping that there'll be some time at the end so we could talk about things and hear your perspective. There may also be some different points that you want to make. So think of this as, I guess, maybe more questions than answers. So as transplant nephrologists, we really walk a tightrope. On the one hand, we function as what I'll call, we have our transplanters. And on the other hand, we're nephrologists. And so it's sort of in between. And just to sort of put this a little more graphically, if we look at this graphic of the process that a patient goes through and the journey they take and everything that they deal with prior to transplant and after transplant. And before I say anything more, I think I've told some of you I grew up in Brooklyn, New York, and this picture always kind of reminds me a little bit of the New York subway system. But so I kind of like it from that perspective. But anyway, and there's a nice diagram of the system. And you can see, I think on the left side are our transplanter functions. I define those as what we do kind of leading up to and trying to get people transplanted. And then afterwards, our nephrology functions. We do a little transplant functions too, but as you know, after the transplant, working to take care of the patient. I think there's a couple of things you'll notice. One is that a lot more space on this graph is on the left side on the transplanter functions, but we'll get into that a little more. But anyway, I think that there are a lot of current factors that are pushing us towards the nephrology, towards the transplanter functions of the system. So we spend a lot of time there. And there's some good reasons. I mean, after all, recently we've really focused on trying to increase access to transplant. That's been a big deal. You may say, well, where did this all come from? Came from many, many things. And perhaps one of the biggest forces behind this is the 2019 Trump's executive order advancing American kidney health. Executive order that I'm sure Suzanne has talked to you about and you're probably well aware of. Now, I'm not talking politics. I'm just going to say though that this was really, I would say this is really Alex Azar's really brainchild, because his father, as many of you know, had kidney failure and was on dialysis and also received a transplant. And so, but during Trump 1, we did give this executive order. And it had, a number of initiatives, very aspirational. For example, here we are in 2026, and in 2025, we were supposed to have had 80% of patients initiating RRT, either with dialysis in the home or undergoing a transplant. We didn't I mean, I don't know about here, but certainly in Chicago, we have not achieved that. I was going to say, but there's a big push towards towards transplant in this, and because of that, there's been a lot of things that have sort of been a consequence. So I would say that one of the consequences, or some of the um, Center for Medicaid and Medicare innovation models to achieve these goals. For example, there was in 2001 the ESRD treatment choices model, which was a mandatory model, and which looked at modality performance scores, with transplant having an increased, a good preferred modality. And this target and who benefited from this was nephrology practices. In 2022, there were the kidney care choices model. That was a voluntary model with bonus payments. So, again, some financial bonuses there. And this, again, was targeted or directed towards nephrology practices. But just this past July, IOTA rolled out. And that's a mandatory model. Half the country, I mean, it's not split down the middle, but half the country is in the model, and half are not. Now, I actually turns out that we share that, because in Chicago, we're not in the model. I understand Seattle, you're not in the model. So we're kind of business as usual. And it's a carrot and stick, or bonus and penalty approach. We were talking about this a little bit last night, and a lot of discussion we could have about that. We don't have a lot of time right now to do that, but this targets a different group. This targets the transplant program. But all of these efforts are really, have a sort of overarching theme of trying to increase transplant. And so, not surprisingly, us transplant nephrologists are sort of, a lot of our time, a lot of our effort is pushed towards the left side of that graph. Other reasons that we're sort of pushed to the left side of that graph includes that the dialysis patients are aging. And so the patients that we're seeing to evaluate for transplant and who are waitlisted are older. So on the top of the graph, you could see that the percentage waitlisted greater than 85 years of age has been growing over time. And so, not surprisingly, mean age of those waitlisted is higher. So there's no surprise there. And these individuals tend to have more issues, more things to deal with and consider. It's not just age, though. I mean, if we think about the folks that are on the wait list or that we're evaluating for transplant, more of them have diabetes, increasing percentage. And so what we're seeing again is an increasing group of patients who have potential medical complications, vascular complications, cardiac complications, other things that come along with diabetes. But that's not just the only forces that are pushing us in this transplanter mode, or pushing our focus, the transplanter mode. Health systems are also pushing us there. Now, I don't know about here, but I got the sense it was true as well from our conversations last night. But in Chicago, there's a real push to grow the transplant program. And that's a lot of a health system push, because I think, of course they want to help patients. I'm not saying they don't want to, but there's a financial, reason for that too. And then, that also takes a lot of our time and puts it in this transplant mode. There's other considerations. For example, in some, not all programs, transplant nephrologists take organ call, and that's gotten more complicated because since 2021, when we had the CAS 250 with the circular geographic distribution of 250-mile distribution of organs, there's just been a lot more offers, a lot more calls, and so this just takes up, it's more complex offers, and also it's consuming time-wise and also just thought-wise about what's involved. So that's also sort of pushed us in that left of the graph. The other issue is that for hospital, pre-transplant efforts are financially favorable. After all, when we see patients for evaluation, we're sending them for cardiac testing, we're sending them for colonoscopies, we're sending them for all sorts of things that they can make money on. And then there's the cost reports that cover non-billable pre-transplant expenses. So that also helps. It helps the hospital. Doesn't help the departments, but it helps the hospitals. So, but that's another push for why there's a lot of, forces pushing us to that left side of the graph. But that's not all bad. I mean, being pushed to the left side of the graph, let's face it, is not necessarily a bad thing, because when one looks at this is an old graph, but it's still the same, the same. But when one looks at the number of transplants that we're doing in the red compared to the number of people that are waitlisted, which was growing steadily for quite some time, it's kind of leveled out, but growing steadily for quite some time, there's a huge gap, as many of you know. So the truth of the matter is increasing access to transplant is critical, because we have so many people on waitlist who want a transplant. But let's face it, it's really not just about getting the kidney. No one wants to get a kidney and then all of a sudden find themselves like going down this route of sort of kidney dysfunction and kidney failure. They want, what people want is when someone gets a kidney, and we want that too for our patients. What recipients want is one, optimally one kidney for life, or a lifetime of good graft function. But we'll get to that later. So that brings up the question, what about the nephrology functions that we do as transplant nephrologists? Well, I think there's also pushes in that direction as well. Let's face it, we have more patients to manage. There are the prevalent number of kidney transplant recipients are growing, and also the number of new kidney transplants that we're doing is increasing as well. So we've got a lot more folks that we're treating. So these are some of the current trends, and these current trends bring up, I think, some important questions. First important question I'd like to, first question I'd like to address is, are we adequately staffed to manage the increasing number of transplant recipients? And my quick answer to that is no, we're not. Now, what, and I think we have some data to, to support that. This is something that, these are data that were put together when actually people were looking at whether we should consider how we could increase transplant nephrologists, and considering whether ACGME was a good accreditation, was a good approach. I'm not going to get into all of that. But when you compare, if you look at the number of sort of, I guess, presumed transplant nephrologists compared to the number of transplant hepatologists and transplant cardiologists, I'm going to leave the pulmonologists out because there are not so many of them, and it's sort of a smaller group. But when you compare those to the number of new transplants, the number of waitlisted patients, the number of prevalent transplant patients, we are really outnumbered. And so we really don't have that workforce, which then brings up another question. Great, so we're really understaffed. And then how are we with this, with the the shorter staff that we have, how are we doing with post-transplant complications and outcomes? And truth is, as much as we all want this, that's not the reality. This is what reality looks like. And let's not forget, as Roy Bloom says, that transplant is not an appendectomy. It's not a cure. And so recipients don't regress to non-CKD states. And in fact, all of our patients have CKD transplant. And this CKD transplant progresses. We know that because if you look at the new dialysis patients, 4 to 10, or look at dialysis patients, 4 to 10% of all dialysis patients were previous kidney transplant recipients. So that brings up another question. When we look at transplant recipients, where is their CKD state? So these data from Spain sort of give us a sense of this. Now, this is data from 2010, so it's not new data. But when the researchers in Spain looked at what the transplant patients, where their CKD T stage would be at 1, 5, 10 years after transplant, I think you see a couple things. One is that most of them are at stage 3 CKD T. But what these old data, these 15-plus-year-old data show is that the majority of transplant recipients are CKD T3 or greater. Okay. So, so that's important. Now, these are all data. Things are different now. First of all, donors are not the same as they used to be. Donors are changing. Donors are older. They have more hypertension. They are more likely to be diabetic, and in part, consequently, their KDPI are higher. We're also the kidneys that we're using are a little bit different. We're not using certainly we use brain death donors, but we're using increasing numbers of circulatory death donors, and we're procuring more circulatory death donors, and we're not using all of them, but we're using an increasing amount. But it's not just donors that are changing. As I showed you before, I showed you that our waitlisted patients are a bit older, they're more likely to have diabetic, and so the recipients, not surprisingly, are older. More of them have diabetes. Their BMIs are higher. And if we look at their dialysis vintage, they're longer. They're on dialysis longer. So, more complicated donor pool. It's a more complicated recipient pool than when that data that we saw 16 years ago was first looked at. So that brings up the question, will this distribution change now that our recipients and our donors are different? And if it does change, then how will that affect our long-term graft survival? Well, turns out we have that answer, because really for the first time in a long time, we're seeing that the 5-year transplant outcomes are declining. I don't think that's a surprise. I think it would be a surprise if they weren't, in a way, when we think about everything that we're looking at. So we have that answer. Okay. So with that answer, let's then go back and consider CKD transplant progression. Okay, this area, if we look at this color-coded area, this area in the yellow to the red part. And let's also take this apart and say, well, what can we say about progression? First, how does it compare to CKD progression in the native kidney? And I have a little good news. I've not been telling you so much good news up to now, but a little good news. Good news is that it progresses slower. And that's true if you look at it by creatinine clearance, or if you look at it by EGFR, it's a slower progression. Great news. And so consequently, the half-life of the CKD transplant is longer. So there's a little good news. So I told you about the top, so you're not surprised that when we look at kidney survival probability of the CKD in transplant versus CKD in the native kidney, CKD in transplant looks better. But here's an interesting thing. When you look at the bottom graph, you'll notice that the labels are reversed. That's because when you look at patient survival, it's not better in CKD transplant compared to CKD native. Now, I didn't say compared to ESRD, I said compared to CKD. So bottom line here is that CKD transplant is a slower progression than CKD, resulting in improved kidney survival, but not patient survival. Kind of surprising in a way, but maybe not. This is not their first rodeo, right? So if you look at the top here and you look at these patients who have CKD, you see, they go through this progression once. But then on the bottom, you look at our transplant patients. They've already been through that progression CKD. Many, and maybe most of them, went on to ESRD. They get their transplant, and then they're faced with immunosuppression, rejection, infection, and now they're going through the CKD progression again, more slowly, albeit, but they're going through it again with all of these added burdens and all of this history. So maybe it's not surprising that they're compared to CKD native, CKD transplants have a lot more issues. And when you look at associated complications of CKD transplant versus CKD native kidney, not ESRD. For general, ESRD is worse. But when you look at CKD versus CKD, good news is the rate of decline of GFR and progression from one stage to another is slower, as I showed you. However, a lot of the other areas are worse. So it's kind of interesting. And also CKD stage matters. So it turns out that CKD transplant stage correlates with complications, which brings up another question then. how are we doing with managing CKD transplant post-transplant complications? So let's go back to this color-coded graphic of the decline of the kidney transplant, and let's just focus first on the sort of early CKD part and ask, well, how are we doing? Our neighbors up north, our Canadian colleagues, Greg Knoll and one of my former general nephrology fellows, Ayub Akbari, looked at that question. And what they did is they took a group of patients who were being managed for CKD, patients who had transplants and patients who had native kidneys. A small group. This is excuse me. This is the two groups, and they asked a couple of questions. They looked at how we're doing with blood pressure control and medications. And what you can see here is that in the transplant group, diastolic blood pressure was higher. The transplant group was less likely to be on ACE inhibitors, less likely to be on phosphate binders. And we'll dig a little deeper into that later. Okay, so I guess you could summarize this by saying CKD complications are not managed as well in transplant patients as in non-transplant patients. And then the question is, why not? Well, I would propose to you that one of the reasons is that CKD complication management is just not well studied in transplant recipients. If you go back to the KDIGO guidelines, okay, well, we'll get to the KDIGO guidelines, but first, let's just think about anemia as an example. We really don't have clear guidance, and the target hemoglobin in hematocrit post-transplant anemia has not been yet determined. Okay, so now let's go to the KDIGO guidance and let's see what we know or what we were told about managing some of these issues. With respect to anemia, if you just look at the language, you see that the language is using standard measures applicable to CKD. That's because we don't have any measures for transplant patients. Okay, so then let's go back to that study from Canada and say, well, how are we doing with anemia management? And if they looked at the transplant patients and the non-transplant patients with hemoglobins less than 11 and how many were not on erythropoietin, and you can see that significantly more transplant patients were not treated with erythropoietin compared with the native kidney CKD patients. So another example is transplant bone disease. And Simon and I were actually chatting a little bit about this yesterday, how little we know about this. And if you look at those KDIGO guidelines, what you see is that, just yellowed a few areas, that we're talking about vitamin D use. It says using treatment strategies recommended for the general population. When we talk about getting BMDs in stage 4 to 5 patients, they say suggest management as patients with CKD 4 to 5 not on dialysis, again, because we don't have any transplant-specific guidance. And if you look at the grade levels, so you say, well, what are these grade levels? One refers to recommend, they use the term recommend. 2 is suggest. So these are not even recommendations, these are suggestions. And then when you look at the level of the guidance, C is a strength of evidence, C is low, D is very low. So essentially what this is telling you is that the level of evidence makes clear that we lack transplant-specific evidence and are left to extrapolate. So how are we doing extrapolating? I think you're getting the trend here. Not so good. And so, when we look at patients who had in this study who had phosphates greater than 4.5 and were not on binders, not a surprise after what I've told you, significantly more transplant patients were not getting binders. You look at the patients with proteinuria, you say, well, how many were not on ACE inhibitors? Significantly more were not on ACE inhibitors. So essentially, we are not even doing an acceptable job of extrapolating goals from non-transplant patients to transplant patients. So it sort of brings me up to this point that maybe us transplant docs aren't doing such a great job as nephrologists, but we'll talk a little bit more about that. So, now it's a whole new world, right? We've got all sorts of things that we can use in CKD. I mean, look, we've had RAS inhibitors for decades, so that's not new. And as you could see, we weren't doing so good at using them. But now we have SGLT2 inhibitors. We've got nonsteroidal MRAs. We've got GLP-1s, all of these things that have been shown to be helpful in slowing the progression of CKD. Now, you might say, but look, they haven't been studied in transplant patients. How should we know to use them? And that's fair, but we're starting to get data now, real world evidence, and so there are a couple of studies, that I wanted to point out to you. This is a study looking at SGLT2s, and it took a bunch of it took a database, and it looked at patients with transplant patients with diabetes. They looked at those who got SGLT2s versus those who didn't. To start with, you'll notice that more patients did not get SGLT2s who had diabetes. That's just beginning. But when they brought it down, they matched them, and then they looked at outcomes. They found those on SGLT2s had less likely of death, and less likely to have a major cardiac event, such as cerebral infarction, hemorrhage, stroke, cardiac arrest. And then they looked at initiation of redialysis or incident dialysis. They found that those on SGLT2s were less likely to have kidney outcomes. So there's actually some emerging evidence that these are associated with better outcomes. They also have some other benefits. In our transplant patients, we often see hypomagnesemia, which can be a sort of pain to manage. Turns out they're helpful in improving the hypomagnesemia, and we also see hyperuricemia a fair amount. Many of our patients suffer from gout, and again, not tends to be associated with improved gout. Well, what about the GLP-1s? Again, emerging evidence, real world data that these may be helpful as well. And this was, again, not a study looking at set up to look at their efficacy, but just looking at patients who had gotten them. And this is, again, another database looking at patients with type 2 diabetes, and similar findings in that more patients with type 2 diabetes were not on GLP-1s, and transplants were not on GLP-1s than on GLP-1s. But they set up two cohorts, and they matched them. And of those two cohorts, they found that there were less like patients had either less cumulative death risk or less hazard risk of death, and also less risk of going back to dialysis. So again, we're starting to have data to say that these may be beneficial in transplant recipients. So the bottom line is we must catch up to our general nephrology colleagues. CKD management, it's a whole new world. And so that then brings us back to this graph of our patients. And let's then look at the late kidney dysfunction. And just again, bring up the point that unfortunately, kidney transplants don't last forever. They usually the patient survives longer, but we know that it's a very difficult and deteriorating course, and when their kidney transplants are failing, and about 6,000 grafts are lost every year. And for any of us who have worked with our patients through this period, it's very difficult. And there are a lot of management challenges and a lot of questions. We don't have a lot of the other transplant areas, we really don't have a lot of evidence-based answers. And a couple of years ago, I was working with KDIGO on a project they were doing on the failing allograft. And so I just decided to ask a couple of my former colleagues or former trainees who were in transplant all over the country, what did they think? How did they find this issue of working with patients with a failing allograft? And so I asked them a bunch of questions. I'm not going to go through every single one here, but let me just sort of get to the bottom line. The bottom line was that everyone I surveyed answered that it was hard to tell patients that their grafts were failing. So it's not just hard for the patient to hear this news, it's also hard for us to share this news. And most thought that it is harder for patients to learn that their transplant is failing than their native kidney is failing. Now, I asked a couple of patients about that. And I said, is it harder to, and what was interesting is they weren't so sure. They said, honestly, it's hard to learn both, and so they weren't so sure that it was hard to learn anything. Maybe for the physicians, it was harder. I mean, that's kind of an interesting area that, one could explore, but I think it's hard for both the patients and the physicians, very difficult. Now, when the graft is failing, the patient is left with sort of three potential future directions. Conservative care, which I'm not going to address today, but I am going to make a few comments on dialysis and dialysis preparation and our patients with a failing allograft, as well as retransplantation. So first of all, I just want to point out that Jeff Pearl gave us, did a nice study where he looked at outcomes of patients who were going on to dialysis with either a failed native kidney, as shown here in the solid, in the solid line, and or a transplant failed kidney in the dotted line. And basically, what he showed there was that patients with a failed transplant have a reduced quality of life and higher mortality, particularly due to infections, than transplant naive patients. So this return to dialysis it's a risky business. Okay, so you may say, well, why? I mean, he tells you a little bit here that has to do with infections, but I think, there's another reason. Infections, obviously you get higher rates of sepsis, but then there's also probably an increased cardiac and metabolic risk from the continuation of immunosuppression after return to dialysis, or maybe the history of being on immunosuppression. There's other contributing factors. I'm getting back to that CKD management that we just don't do so well for our transplant patients. There's immunosuppression management, and there's also lack of dialysis access in many of these patients, which I'll talk about in a little bit. So if you don't believe me that we don't do well with our patients in terms of management when they're returning to dialysis, we can turn to a piece of work that came from Ann Hummel at Cleveland Clinic. And what she did was she looked at the USRDS. She looked at patients who were going on to dialysis, who either had a failed a transplant or a failed native kidney. And she looked at anemia parameters and bone mineral density parameters. She also looked at access. I don't want to talk at all about. I'll talk about access in another couple of studies. But when she looked at these anemia parameters and bone mineral density parameters, I don't think it's going to surprise you to tell you that patients going on to dialysis with a failed transplant, their parameters are not as good. So basically, we are failing to control complications of early as well as late CKD in transplant. So what about preparation for dialysis? So Greg Knoll and colleagues looked at this as well. And they looked at whether access was discussed, whether patients had access referrals, whether they were access ready, and there's significantly fewer of the transplant patients had any of these things done than the patients whose native kidneys were failing. So, I think you all know this. The access really matters. We heard a story earlier about how someone really went to bat to try to help someone with access. This is a really important issue. And when returning to dialysis following a failed transplant, it turns out that the lack of having an AV fistula is associated with a 22% increased risk of all-cause death. The use of a central venous catheter is associated with a threefold greater risk of sepsis after transplant failure. And here, getting back to my contention that as transplant, and I really apologize to all the transplant nephrologists in the room, but I am one, so I can say this, I guess, that us transplant nephrologists are not really great at this. It turns out that lack of referral to a general nephrologist is a predictor of catheter use, which I just showed you is associated with all of these bad things. So Chan at University of Wisconsin and others looked at this, but Chan looked at this specifically. What Chan looked at was access preparedness, and so Chan looked at the presence of an AV fistula and the use of central venous catheter. I'm not going to get into the graph part in patients with either a native kidney failure or failed kidney transplant. The failed kidney transplant is the solid line, and the native kidney is the diagonally slash line. And you could see a couple of things. You could see that, okay, if you look at the AV fistulas, you could say, but wait a second, we're doing better. Look at that. We have more AV fistulas than the native kidney failure. But B. Concepcion, my colleague, pointed out something really interesting to me, and I have to agree with her. She said, I don't think we can take credit for that. She said, you know what? Probably most of these fistulas were present through the patient's transplant, and these actually had nothing to do with us transplant nephrologists. So that only really brings home the point of how we're really not preparing our patients. So I would say, although arguably better rates of AV fistulas are present in people with failed transplant compared with failed native kidneys, rates are still quite low. And an unacceptable 60% of patients with a failed kidney transplant started dialysis with a central venous catheter. So not good. We really have to do better. And I think part of it, I mean, it's probably many explanations we could talk about it. It's very hard to admit failure. It's really hard to see that the patient's transplant is not working. But anyway, then the question comes up, okay, fine. But is there a survival benefit? And I have some good news for you here because I've not been sharing such good news. Yes, the good news is there is a survival benefit. So absolutely, retransplant your patients. It's good for them. But there's a caveat. The caveat is that it really depends when. Timing matters. So this is a study that came out of Austria. Kahns et al. Did the study and looked at on retransplantation, at what point do you lose your survival benefit? And it's about 8 years. So really, if you're going to transplant, the sooner you retransplant, the better off you are. So a couple of thoughts here that I want to share. As I said before, transplant is not a cure. It's not an appendectomy, as Roy Bloom said. It's just a form of kidney replacement therapy. Our patients still have kidney dysfunction. We can't lose sight of that. The truth is that, it is very hard for those of us in transplant, for many reasons, to talk about kidney dysfunction and to address associated complications and comorbidities, but we must. We have new CKD tools, and they appear to be helpful post-transplant, so let's use them. Let's learn how best to use them in this population. My contention is that we transplant nephrologists are nephrologists, and we need to do a better job of incorporating and not simply functioning as transplanters. So we need to spend a little time on the right side of that graph that I showed you earlier. So I'm going to play the devil's advocate here. This is not the end of this discussion. So, but there's another point to this. I showed you we're being pulled in two different directions. We're on this tightrope. Maybe we're juggling too much. And so with playing the devil's advocate, and also think about another point of this, if you consider it from a financial perspective, post-transplant work is not lucrative. Let's face it, post-transplant care does not generate much revenue, and the work entails a lot of non-billable hours. So in a way, in the current system, which unfortunately is, very much built around billing and revenue, maybe we should be spending more time on the transplanter functions. It's a question. So it brings up the question, is it time to take the nephrology out of transplant nephrology and partner more closely with general nephrologists for post-transplant care? Or should we start doing better? I don't think it's necessarily in either or, but I put it out there as kind of an either or sort of a, provocative point. So I'll stop there, and I'm really interested in your perspectives. Yesterday we talked a lot. I think there's a lot of things to think about. I thought of this as a little bit as a talk on transplant nephrology identity, because I think we are in a little bit of a identity crisis. And I think, as we spoke last night, there are a lot of areas, a lot of points that relate that may be a little bit tangential. So again, just want to thank you. I'm interested in your thoughts. Yeah, Nikolai.
Very inspiring. To me, the main message is that maybe we do need that transplant nephrology, the STP, Society of Transplant Physicians, because I do think the transplantation is at the crossroads right now. For example, to me, it resonated a lot the graphs that we showed that the CKD transplant was better than the CKD and the native kidney, which I think is a great move. Obviously, the curves were flipped on looking at the patient survival, but we need to remember that dialysis is out.
Right. And just to interrupt you for one moment there, it's not compared to ESRD, that's compared to CKD, right?
Right. So those curves are in a way that mortality is not reflective of the true data. But what I am reflecting on is when you think about transplantation, what we do today, we transplant older patients, right? So more than 50% are over 60, soon they will be over 65, right? On the kidney transplant list. The margin of the donors, the way we grew close to 30,000 soon, it's even through utilizing both the donors, as you showed, with diabetes and hypertension. So it's a combination that puts us in a little of a bind. The biggest bind that we have to deal with as a society is the death paradox, right? So I'm going to take this to an extreme just to exemplify that. If you transplant a 75-year-old, right? What is defined for a bad outcome? To me, a bad outcome is if that patient becomes dead. Where is that treated as a positive outcome into that patient? A 75-year-old had probably 1 year survival on average as a whole interstitial disease population. Maybe he will die 5 years later with a 5-fold improvement in survival. But why? How do we deal with that in a way that is truly reflective of the new landscape of transplantation? I think just showing mortality graphs that show a negative vibe for transplantation is not sufficient. We need to break that. We need to find better markers that show our work in those.
Yeah, no, I agree with you. I mean, it's so I think it also brings up the issue that the landscape is changing, and I think I think we transplant people come to transplant with the expectation of their outcome is going to be as if they're going to get a living donor kidney, and from a young person, and that they're young, but that's not who's coming. So we have to sort of be able to convey the message of really manage expectations so that people know what they're getting into, so that they can make choices, understanding, they're going to go down the transplant route. It is going to improve things, but for them, but maybe not in the way they think, because there's also sort of this fairy tale myth around, transplant. And the reality is now, for some people it's a fairy tale, but the reality is not for everybody. And the best that they can get, maybe an improvement from the current state, but maybe not the nirvana that they were thinking, hoping for. Nisha. Yeah.
Fabulous talk, Michelle. I'm thinking about a parallel that other fields have gone through this, and one that comes to mind is HIV care.
Yeah.
Where initially it was really about getting the patient alive in the short term, and then there was this shift in that field where it became chronic disease management. And I kind of see the same parallel happening here. And somebody who I've worked on a bit on like the CKD management side, and everything we write, it's always saying, we don't know if this applies to transplant patients. Do you think, you talked a little about therapies. Do you think there's also a need? Something as basic as do a blood pressure trial in transplant patients. What is the right target?
We don't know.
There's enough there that we can extrapolate from the general population.
Yeah, that's a good question. We certainly, I think especially with the number of prevalent patients, we probably could do that. And then it would potentially, or maybe maybe it's hard to do a trial just because of everything that's involved. Maybe just having more real world data might be easier, but I think we do need to get that one way or another. We need to get that data and to answer that question, as opposed to just to shrug our shoulders and say, well, we don't know. Yeah. And extrapolate. So one way or the other. Question is how to get it done. Even a small step. Yeah. Even a small step would be great.
Thanks, Michelle. I'm both inspired and questioning my future.
Right. Well, I questioned my future with the first talk.
This is valuable in many ways, including the value that we all have in sitting in the same room and having shared identity to work through how we're going to deal with the future together.
Right.
We all hold similar identities in some way, whether it's nephrologists or as medicine folks or as something related to healthcare. And as I consider the potential challenges that we face in transplant, there are many similar challenges in general nephrology. And I think that we can learn from each other. One of the things that we, I think, do well here that other programs across the country don't all do is that we share the care after transplant in ways to integrate knowledge and capacity. So, for instance, CKD management may be better by general nephrologists, and can we leverage that knowledge? That requires communication, and I think part of it that we need to continue to work on is how to best communicate and leverage the technologies. In the course of the hour that you've talked, I've gotten 2 text messages and 2 phone calls from different doctors around the WAMI region that I need to return. That's part of the challenge. Right? I think the other parallel that I'm thinking about in considering how to deal with all of the transplanter functions on the left side of your subway figure is much like in general nephrology, we're facing how to deal with the onslaught of CKD patients, stage 2 and 3, that we, as a general community of nephrologists, are not prepared for. Transplant is highly regulated, and we are being pushed to move from the 28,000 transplants we did in 2025 to 66,000 transplants in 4 years. That's our challenge, right? Are we going to get there? That requires at least a 4-fold greater number of evaluations than we will do transplant. And it's much like the CKD management challenge that we in general nephrology as a whole are facing. How are we going to deal with that onslaught if we are really going to try to prevent disease progression by seeing them earlier?
I don't have the answer, but you're right. So I agree with you. It's a really, yeah, I think so for transplant, I don't know what you're doing here, but for transplant programs, what I've sort of a trend that I've seen is that, many programs would continue to manage all of their patients forever and ever and ever. And then they're like, well, we can't, we just can't. Or the hospital says, you can't do that. You can't, you have to send all the patients out and after their transplant. And I guess I have a couple of feelings. And I'm interested. I have several feelings about that. First, from what I do, I really enjoy working with people after transplant. I mean, that's actually kind of the joy to work with them and to help them navigate their lives after they get their transplant and try to keep them healthy and deal with complications they may have. And so if you say, depending on your program, well, after 3 months to a year, we're going to send them to their general nephrologist. I sort of feel like that's part of why I went into this. And so that, so I have that sort of a negative in terms of the profession. But at the same time, I do recognize that it's not, one, I might not be doing the work quite as well. And then two, that it's really hard as we're trying to increase access to sort of, to do both. And then I also feel, I don't know if sometimes I feel like we're sort of saying, everyone's saying like, well, we can't do it, but the others can do it. Like, why do I think that that the many general nephrologists out in the community have the capacity to take all of these patients on? So I think we have to think as a group. I think you're right. We can't silo ourselves, say, well, we're transplanters. We can't do this. Everyone else will take care of it. You're community physicians. You can take care of this, or you're, academic general nephrologists. I think we do all have to think of it together and figure out a solution to make, first of all, our ability to work effectively, and then also to take best care of the patients. But maybe going back to the first talk, maybe AI or some other upcoming can help us. I don't know.
I was actually just going to add the other piece of that the patient.
Right.
I think what I've known from the when you go through the experience of the patient, that can be very powerful.
100%.
It's just something else.
Yeah. No, I agree with you 100%. And honestly, I don't know what but a lot of times the patients do not, they feel like there's not 100% abandoning them, because we say but they do feel a sense of abandonment. Like, what? You just took me through this journey, and now you're saying, okay, go back to your general. Yeah. Yeah. So what I tell them, and again, maybe this is, I'm thinking about your thing about, phrases. I would say, well, we never say goodbye. We're, trying to say the door is always open and we're always here. But, but still, it is, I know that if I had a transplant and I felt like, you're my safety net, you're my, you've helped me through this. And now you're saying goodbye, we have to take care of the next group. That sort of feels like not good. But it's an issue. Yeah.
Thank you again. But one of the comments that Chris just made really got me thinking about, well, am I even going to have a job? Although the earlier slides imply that there are nowhere near enough transplant nephrologists to address the population we have, let alone how do we attract more? Because I think the job safety is here. All the things that you do with that subway station, and you're not getting in fact, coming like Lou again, who just said yesterday on a phone call that there are about 4 hours worth of things that transplant do every day that we don't get reimbursed for. And so you'll have people in the community starting to talk about, for example, getting homes, which transplant nephrologists don't have, and they have that without these patients have. Was that something welcoming fruit perspective, so you can get your users pay for the work that Chris is doing? And then the second thing, this is a really outside of the box. I mean, dialysis we hate it. We hate it, but they think about all of the parts of the bundle, and then they pay for the amount that we see on cost reports and process percentage that MedPAC talks about every year. I mean, is it worthwhile even thinking about a transplant bundle, whether it's for the system or for transplant nephrologists, to capture all the things that you do, which might then attract people to the field if they can compensate their work.
Well, no, I think that's a great question. So I'm not working as closely with ASN anymore, but I know that in the midst of putting together a toolbox about this issue, about transplant nephrology compensation and in it, Melissa West is working on it, and Curtis Pivert working on it, along with Rachel have been working on it as well, to look at, to sort of break these things down. And so, and one is an educational tool for the administrators and the hospital leadership to sort of understand what's involved. And so, it'll be interesting when they do that to see if that will then enable them to take next steps to do some of the things that you alluded to. So it's sort of step one, I think. So we'll see. I think, okay. She was like,
I guess I'm just going to play devil's advocate because I feel like the undertone of your talk is that transplant nephrologists should be doing more. I feel like our transplant nephrologists are already doing so much, and we're all doing so much, you know, to aid the physicians with doctors and burnout. And as a general nephrologist, I have trouble keeping up within the general nephrology, so I can imagine that the transplant nephrologists have trouble keeping up with their field. And you could have the corollary to this for us is put the internist back in the general nephrologist because our patients can't get primary, you know, our patients
right.
can't get their shoulder pain, their H. pylori, and and you just can't keep up with all of that. So I'm not sure that this is the time to ask people to become more generalists and less specialists with the emergent.
Fair. No, I think that's a fair question.
You've been through everything and you want to be if you're a transplant nephrologist, but if you have a general nephrologist who's been taking care of you for years, many patients actually want to go back to their general nephrologist and have strong relationships. I guess the question is, what's the best balance? Like, should our transplant nephrologists see our patients once a year, twice a year? How can they be available to us best to help with any especially detailing things that, you know, we don't feel comfortable with? So I think working on that balance rather than just asking more.
I think it's an absolutely fair point. Yeah.
Question, actually, I'm gonna ride on the data. So what you've shown so far is that, you know, CKD patients after transplant are not exactly the same as CKD native patients, right? So when we send our patients back to our nephrology colleagues, and we expect them to treat the patients like CKD native patients, is that the right move? I mean, Karen and I were just talking, you know, like our patients a lot of times post-transplant in CKD 3, 4, they're hypophosphatemia. They're not hyperphosphatemia like the native. So like, I think every time we say, hey, we just extract, you know, data from CKD, it's not exactly the right thing. It's just.
So that gets back to Nisha's point, we have to study this more and we have to learn more. Yeah. We'll do that in our spare time. Yeah.
Great overview. I'm at the Seattle VA, and most of the transplant patients get their transplants at Portland, although some go to UW and other sites. But most of the visits after the first year are done by a nurse practitioner who actually becomes and learns and becomes the local expert in transplant CKD. And then she has other general nephrologists that she can ask questions to. And of course, she gets support by, if she has questions, calling the transplant center. Now that seems to work. Now, one of my questions is the mechanism to pay the transplant nephrologist, because she'll call them, and of course, they're not billing for answering the questions. But the other thing we have at the VA is we have a lot of non-visit consults. I think other sites have them. I mean, that's one of the things I do mostly, and we had over 400 last year of non-visits consults, which is useful. We get them from all over, Alaska, all over the division, and primary care physicians who have questions about patients who don't need to be seen by a nephrologist can get a really very detailed view, and you get a surprising amount of CME, or not CME, of charges for those non-visits. So my question is, could, for example, transplant nephrologists, instead of answering the phone, answer an official non-visit or e-consult from general nephrologists or the nurse practitioners who have these questions, and instead of calling them, say, put in a non-visit, an e-consult, then you can bill for them, and you bill sometimes almost as much as a quick visit, and that would be a way to solve the issue.
Hi, maybe, yeah, that's a great idea.
It's currently happening actually at the Portland VA. So we have, in fact, they've told us that they don't want to see them necessarily, our patients, after 2 years. Then any question after that, we're not. I think one of the impressions I've had, just as a comment, right, sort of built in, but you know, who are we considering transplant in now? And at the VA, our patients are older. They have more comorbidities. And so they are definitely a more complex group. And so I think, and you know, that's because potentially we're keeping healthier people away from that question. the different drugs that we now have. So the transplant question is in a different patient population.
Yeah. Yeah, no, it's interesting. I think we even see that more so, right? Because as we start to treat people earlier and hopefully delay things, I think it's gonna be a very different population that we transplant and bring up all different new questions. Yeah, agree. Yeah, Josh.
So I guess looking forward, I think there's a lot of challenges kind of on the horizon, and one of the best ways to prepare for those challenges is to go back to public training. And I guess looking about to graduate fellowship in a few months and looking back, I'm not sure I've been prepared to manage CKD transplant, and I think we'll probably have to rely a lot more on general oncologists to this care plan. So how do you see changing?
The quality of the train.
How would you see like general oncology training changing the drug?
Well, that's a really interesting question, and I'll just get back to some of the ASN work that looked at changing the fellowship structure, and it came under a lot of scrutiny because there were people who were very concerned that there was not enough transplant training, even in the changed blueprint that came out a couple of years ago that I guess is rolling out. So I think that, I do think it is really important that we, that the general nephrologist has solid transplant training to be able to address these things, especially as we partner, because we are going to partner. We are going to partner more. We do have to partner more either in one way or the other. So I think we 100% need to think about that. And so I do think that it will, that with that training, hopefully people will feel more comfortable and even if you don't do a transplant nephrology fellowship, you'll have a good basis. I mean, a number of my transplant nephrology fellows have gone into general nephrology, but they bring with it, their transplant training, which has been, I think, very helpful to them. But I think, also just making sure that there's more transplant training in the general nephrology fellowship, because you have nothing else you're doing or having to worry about, right? So, but just making sure that that there is better training, I think will, and more exposure would be really helpful. Yeah.
All right.
Okay.
Well, thank you so much.
Thank you.
Thank you. Both of our speakers today for very thought-provoking talks today. So with that, we'll end. See all of you guys back next week for another in-person Grand Rounds as well, okay?